Welcome to Research Perch from the Massage Therapy Foundation. Short, practical insights into massage therapy research and how it can benefit your practice.
Hi, welcome to Research Perch. I'm Lindsay Bodkin, Vice President of the Massage Therapy Foundation, and I am so excited to have Whitney Lowe and Doug Nelson here with us today to talk to us about pain and massage therapy. So both of you have been tremendous advocates for the Massage Therapy Foundation, and we cannot thank you enough for being here and donating your time and expertise. So Doug, would you like to give your a little intro to your biography real quick?
Sure. Well, hello, everyone. Again, my name is Doug Nelson. I am a licensed massage therapist living in Champaign, Illinois, and I have a clinic here that called Bodywork Associates with 20, I think we have 23 therapists now. And this April is actually our 42nd anniversary of the clinic, which is wonderful. And also my 40-something anniversary. I don't know what it is, but
40 is the new 20, Doug.
Yeah, thank you. Nice save. That was awesome. So yeah, so more than 42, probably 45 years, something in that practicing. I have a teaching institute that teaches precision neuromuscular therapy around the country. But I think the primarily the thing that I would say that is who I am is I live in the clinic. I saw people this morning. We're going to finish this. I'm going to run back and see people all afternoon. So for me, the clinic is the laboratory. That's heart and soul to everything that I'm doing with this work.
Thank you so much, Doug. Whitney?
Yes, welcome everyone. My name is Whitney Lowe. I'm the director of the Academy of Clinical Massage. We are out here in Sisters, Oregon, in beautiful Central Oregon. And I've been doing the massage thing for about 36-ish or so something years. So I'm a newbie compared to Doug.
Yeah, right.
Yeah, I'm a youngster. So, but our primary focus here is on producing educational materials for the massage therapy profession, focusing mainly on the realm of treating pain and injury conditions is kind of our wheelhouse of where we specialize. I'm really a research and learning junkie, and I've been producing articles, blog posts, online courses, training programs, all that kind of stuff for many years, and very fortunate to have worked with just some wonderful, passionate students, practitioners, and educators all across the country trying to help forward our profession. So glad to be able to do that again, and very honored to be able to be sharing the microphone with Doug here this morning, because I do certainly admire all the things that he's been doing over the years as well.
Oh.
I also want to mention that Whitney has the Academy of Clinical Massage Basics of Research Literacy program. And I encourage those of you who are listening to participate to gain free CEs while supporting the Massage Therapy Foundation. So thank you for providing that as well.
Yeah.
So today we're talking about pain. And there's a lot that goes into that. So I'd like to kick it off.
Well, I think one of the things that comes up is, what is that? What is pain? It's a word that we throw around a lot, but actually understanding what that is at a little more granular level. Like, for instance, there's those people who know more, like we therapists might talk about nociception, but there's actually a slight distinction between nociception and pain. And I've heard Whitney explain this many times and does it eloquently. So Whit, if I can shift to you, you want to start with that?
Yeah. So these are some complex terms. If again, like Doug was saying, if you read any of the literature, listen to things, you'll hear that term nociception bandied about a good bit. So think about nociception is the signal essentially, and it's like an electrical signal that's traveling along maybe an audio signal. I love to use the sort of a metaphor of a stereo system. You've got a signal that transmits along the wires, but it doesn't make a real sound until it gets to your speaker. And so a lot of times that's kind of like where we live as massage therapists is we hear the speaker because our clients tell us this hurts or that hurts or something like that. That's where the speaker system is happening. But there's also some really complex things happening at the amplifier level, which is the brain, which is processing those signals and determining, like, is this going to be music, or is this going to be noise, or is this just going to be a signal that's just not enough to make anything happen? So think about nociception as that signal that gets transmitted, but it doesn't really become pain until the brain interprets those signals to a certain degree and just says like, this is worthy of turning into sound. We're going to make some music with it, or it becomes pain, you know. So that's essentially the difference between what we refer to as nociception and pain.
You know, I think all of us, every day in the clinic see this realized as, like I just had someone this morning, when I was on an area, she was like, oh my gosh, that is so, you know, painful. And she said, don't move from there. That is awesome. Right. And it's like, I mean, think about that. Right. So it's an amazing thing of, in that signal, somehow the brain is determining hurt from harm. Right. And saying that is, yes, it overtly, is that painful? Absolutely, it's painful. And yet, right, it is not harmful. This is actually incredibly beneficial. And, you know, we all, you know, we throw around the you know, hurts good kind of thing.
Yeah.
But actually, anything like that, when you think about it, it's an amazingly complex. How does the brain know that? How does the brain make that decision, take that signal, and then say, yes, but this is what it means, and it's potentially really helpful. So that is amazing. There was also, I just saw a little bit ago, a really interesting study that came out of, it was published in the Frontiers of Neuroscience in July of 23. And what they were looking at is just examining, like in the brachioradialis, when you're on a spot that the researchers had determined, like this is an area of tissue disruption, and they had some really cool electrical ways of measuring this. When you are on that spot, the unpleasantness factor, you know, diminished markedly. And when you were off of that spot and just pressing on other parts of the muscle with, you know, fairly firmly, it was uncomfortable, painful, and unpleasant, you know? So it's, again, it's totally fascinating how the brain makes that determination. And yes, somewhere it's being interpreted, right? And that's a mystery.
Right. One other thing I would add to that too, and many of you, I'm sure, experience this when you're working clinically, that time when you're working on somebody and they're saying like, oh yeah, how did you know that that's where it was? Like, how could you tell that that's where it was? And there is something extremely valuable about that whole process of identifying and re-identifying for them this painful thing that they've experienced or felt before. And that has an incredible therapeutic power to it. So the ability to sort of re-identify and acknowledge those places in people is a big part of what's really effective about massage therapy in treating pain conditions.
So Whitney, what you're saying is validating a client's pain during treatment can be very profound and beneficial to their.
Yeah, absolutely. And Doug, you had some stuff, you had a couple of recent podcasts and some other work you've been doing around this issue of validation. So tell us about that a bit.
Yeah, but you know, you just nailed it. You know, for the person on the table, you know, somebody I saw yesterday, I'm just like a little, it was a powerful experience, because she looked at me and said, thank you for making me feel not crazy, you know, because her symptoms were so elusive and she'd seen multiple people, and then she began to doubt herself. And then, you know, some skinny Norwegian comes along and, you know, can replicate her pain through the pressure. And that deeply validated her experience. And really that validation is just the establishing that their experience, their pain experience, is real and true, and accepting that, and, you know, also accepting that and communicating that to her, you know, in a way. And we're so lucky in some ways. There are many ways to do that verbally, but we get to do it through the power of touch. You know, there is nothing quite so powerful as to being able to put your finger on that and be able to replicate someone's symptoms. And you know, you can talk about that afterwards, but the visceral experience of that is so powerful. And I think it's probably, we as a profession would probably see more of that because of this thing of the kind of pain that we see. The technical term for this, if you're looking in the literature, is nociplastic pain. but it's pain that it really often cannot be seen through imaging or some sort of diagnostic, criteria like that. And I think, at least for me personally, the overwhelming majority of the kinds of things that I see fall into that category. And there's something, when a Western society really kind of holds dear this, and there's a term called medical endorsement. But when you get diagnosed with something, if there's an image that says, here's what I have, look, it's right there on the screen, there's that alone is incredibly validating, which is nice. But what about the other side of the equation where, in fact, there's nothing to see? And several conditions are like that. Probably low back pain is one of the most important factors in this. You can take an MRI, but it doesn't mean that what you see in the screen is actually related to their symptoms. Or what if nothing shows? Like, for instance, the person I saw yesterday, she brought her MRI results and they were completely unremarkable. And to her, that was like, well, now what? What does that mean? And that's a really difficult position to be in. So validation, the other thing about validation is, like, when we had that moment and looked in each other's eyes, that built a layer of trust. And that, once this person knew, oh, he gets this, he understands me, now we have deepened that therapeutic alliance, that relationship between, I really take issue with the provider, patient provider sort of idea. It's about human to human connection, in a profoundly vulnerable way, that this other person understands me. And so now the research data really shows that people will be more likely to follow like suggested protocols and things because the level of trust has been built, and that is also invaluable.
Yeah. One other thing, just before we move on, I just want to make one other quick comment about what you were talking about with the imaging there too, because there's another flip side that's really interesting when we think about pain and how people relate that to what's going on with imaging. There was a study, and I can't remember the exact title of it, but they were looking at the relationship of how imaging influences people's idea about their own pain. And they had a group of people who had back pain, and they took them in and they gave them all an MRI, and then they came out and then they showed them these MRI results of this really messed up back. And they had them measure their pain before going in for the MRI and then measure their pain after coming out of the MRI. And a very significant percentage of them reported increased pain after seeing the MRI image. The thing they didn't tell everybody was that wasn't your back that you were looking at. It was somebody else's sort of messed up image that we were looking at. But what that really does illustrate is how important those visual perspectives are, or what people may be told by some of their other healthcare professionals about, how important the image is in your perception of what's going on with you. So those images have power, not always in a good way, sometimes too.
That's so interesting, Whitney. Here's the really funny thing. I'm pretty sure that study was done at the University of Oregon Health Sciences.
That's right.
Yeah. And the other thing is that the MRI was invented right here in Champaign-Urbana. So it's a funny connection to all
right.
of that.
Yeah.
But can I just build on that one more thing, which is that is what is called the nocebo effect, right? We're familiar with placebo. But the nocebo effect is where you think something is actually, potentially harmful when it's really not. There are two really interesting things about that. One of them is that, and this almost goes with the reassurance thing, but in the nocebo effect. So I was just presenting at a conference at the University of Oxford, and before me, this person talked about placebo effect, and that's her whole research area. I thought one of the takeaway lessons from her was, as much as you think we could make the placebo effect work for us, that is potentially problematic and not as helpful as actually decreasing the nocebo effect had a greater clinical outcome than increasing the placebo effect. And the other thing about that in the placebo thing is that can tend on shade toward reassurance, like, no, don't worry about that. You're going to be fine. And oftentimes the person hears that as, you don't really care and you don't really get it because you're being dismissive about my experience.
Yeah.
So it's interesting how all of those things tie together.
Yeah.
So I'd like to back up just for a second, Doug, because you did talk about the nociplastic pain. And for massage therapists out there, can you explain the difference between that and nociceptive and neuropathic pain?
Whit, you want to take that?
Sure. So we often have these, well, what was formerly more commonly two categories of pain, the nociceptive pain. And this is the thing that you commonly think, I banged my elbow on something, I sprained my ligaments, or I tore my tissue or whatever, and then this is painful. So nociceptive pain is there's tissue damage, there's clear indications for why an individual has pain, and then those signals get transmitted back to the brain and spinal cord and become the pain sensation. And then there's neuropathic pain, which is pain that is damage to the sensory transmission signals, in this instance, the nerves. So this is nerve pain that usually comes from, let's say, inflammatory irritation or chemical irritation of a nerve, like, inflammation around something that's causing nerve irritation. And so the dysfunction in those neural tissues produces pain sensations, but there isn't really significant tissue damage producing those kinds of sensations. And that's what we refer to as neuropathic pain. And then the nociplastic pain that Doug was referring to earlier is that stuff that falls in the bucket of, like, we don't know why. This just like something is causing the pain system to get amplified out of control, and we don't really have we can't see it on imaging. We don't have, chemical tests that can pull it up. There's just not a really good rationale or reason why the pain system seems to be out of calibration, causing those sensations to be felt.
And that, again, tends to be more likely. There are a lot of musculoskeletal conditions that fall into that realm. What's interesting, I saw some a thing in the Lancet that came out in the fall, and if you just look at the proliferation, the increase in musculoskeletal conditions from 1990 to 2020, it was 123% increase, and the projected increase between 2020 and 2050 in the next 30 years is 115%, and that's globally. So while we think, we as therapists think, there are folks out there, it is a tsunami of pain out there, and the question is, for many of those people, I think they're a bit adrift and lost as to where to go and who to see and how to deal with it.
And I think the massage therapy profession should take those statistics as a major takeaway understanding of, we've got a lot of people out there in need of our care. So there's no shortage of people out there that we can be benefiting. And I think Doug and I would be screaming on this bandwagon that it's also really important that we educate ourselves better to learn how to help manage a lot of the things that are going on with these people. So we've got big challenges to address profession-wise, but there's certainly and there will continue to be a tremendous need for the services that we have.
And people are helped not so much by, in a way, your skill set, but by the depth of your understanding.
In your experience, what are some of the most common misconceptions about massage therapy for pain that you both encounter from either clients or other healthcare professionals?
I would say the one that comes up for me first around that is the common clients that come in like, oh yeah, my back's hurting, just get in there and dig it out. It's like there's this idea, like, the deeper, the harder you go, the better it's going to be to get me out of pain. Like there's something in there that needs to be retrieved and pulled out, and it's going to work because you're going to press on them harder. And I think a lot of the pain research that has come out in the last several decades has sort of told us that's not really the best strategy in many situations. And in fact, it can be detrimental in a lot of situations. So I think there's still some misconceptions around, everybody's heard the phrase, no pain, no gain. There's and that kind of comes over from a lot of the sort of sports training world mindset. But there's a lot of different ways in which people can, like all these different types of pain that we were talking about, they respond very differently to those kinds of things. Somebody with long-term nociplastic pain sensations, you think about the fibromyalgia clients and the people who have these kind of long-term chronic pain problems. You go in and start doing really deep, vigorous kinds of things with them, you're probably not going to have good results doing that. So that's why that's a common misconception I think we need to adjust.
And I would echo that. That's exactly my first thought when I hear this question. And, I would say in general, healing can't be inflicted. That would be a general statement.
Yeah.
But it's interesting, Lindsay, what I tell my, therapists, my staff, my, students, whatever, is that, sometimes clients, the things that they say is kind of code. So for instance, when someone says, I don't know, that maybe it's there, but if you just press harder, that is code for you're in the wrong place. Because I can absolutely unequivocally guarantee you, when you're in the right spot, no one ever asks for more pressure, ever. And this, it's the same if we agree that touch is language. If I say something to you that, like, for instance, if I said that, in general, healing can't be inflicted, and I see Whit nodding, I'm pretty much assured that if I said it louder, he wouldn't understand it better, right?
What?
It was, hey, wait a minute. So play along with this, but and so pressure is like volume in communication, and actual communication often has very little to do with volume. It has to do with clarity and accuracy, right? And so I think if we hear that, what we need to know is we need to do something differently. We need to change our position, their position, but that is code for you're just not there. And I think when people say that, what they're really saying is they're looking for you to connect to something that matters to their nervous system. And oftentimes the answer to that is often surprising in ways that you wouldn't expect. So,
yeah, I'd like to go back to that stereo analogy that I was using before, because I think that's apropos here. And, Doug and I both have backgrounds in the music world, so we can relate to this. But, bad music played loud is not better. It's just louder, bad music. So the thing that I always really like to encourage people is play good music in your treatment room.
That's right.
I'm not talking about just like what you put on to listen to, but I'm just talking about what you do with your clients. Play better music, because that's what their nervous system is going to respond to.
What? It's interesting. Last week before, I saw the Chicago Symphony, right? And if I said, hey, Whit, I saw the Chicago Symphony and they did the Tchaikovsky piano concerto. If your response was it really loud? Right? I would go, what? Like, there were some cases where the violins were playing. I could see the bows moving. I was leaning forward to try to hear it. And other cases where I felt like I was plastered to my seat, Good music is loud when it needs to be and soft when it needs to be. It's all about what are you trying to convey, not about the thing itself.
Yeah.
So,
and I have to tip my hat to my father, who told me when he was trying to learn to play the banjo that he was always told, if you can't play good, play loud. I don't think that's necessarily true.
Yeah. Lindsay, I'm so sorry.
And so we diverge. Yeah.
Yeah. When Whit and I get going, look out. Yeah. So
do you want to talk a little bit about the burden of pain on our society? I want to take a step back a little bit and just kind of be a little broader here. If you want to go into that a little bit.
Yeah. Well, at one of the massage therapy research conferences, I'm maybe I shouldn't quote because I don't know who it was. It might have been General Bruckenmeyer, actually, who said, we don't have an opioid crisis in this country. We have a pain crisis. And, you know, that is really elegantly stated by somebody, you know, who has deep knowledge of this kind of thing. There are so many people who struggle out there with pain. And that has only increased actually post-pandemic. I think, you know, the pandemic had a way of finding the fault line in every aspect of it, certainly in our healthcare, you know, system. And to one other aspect about that is that, you know, I'm lucky enough to every year I get to guest lecture at our medical school at the University of Illinois. And I can tell you that the students, I've done this for years, but the amount of preparation they have for musculoskeletal issues, for instance, is underwhelming, and they know this. And yet, I think it's the second, I'm pretty sure it's the second most reason that people seek medical care. And there's a disconnect there. And unfortunately, that's not great.
Mm-hmm.
You know, here's another thing. I looked this up. I think it was for 2018. Those are the figures I could find, that NIH funded about $7 billion in research on cancer. And the research on neck pain was just over $500,000.
$500,000?
Yeah, so that would be probably a study.
Wow.
Yeah. Huh. You know, and that was my own digging through the literature. So, but I think, and I get it, you know, very few people have died from neck discomfort, right? But how many people out there are suffering? I think neck discomfort is the third most reason people file for disability. So, you know, you know, there's mortality is one thing, but just the cost of human suffering, the numbers are staggering, actually.
Yeah. Wow. That is amazing. And, you know, again, when we look at those same statistics throughout the population, and then refer that back to, and this is something we were talking about earlier too, is just look at what's sort of structured in the curricula of many of these healthcare and healthcare professions training programs. They're not skewed towards the largest percentage of reasons that people come in for care, which is a lot of that has to do with musculoskeletal pain conditions. And, you know, we aren't owned by big pharmaceutical companies and big income producing organizations. And I think that's one of the reasons why there's sort of a lack of interest in research funding along those areas as well, too.
Exactly.
So, yeah.
Yeah. You know, and again, just in the broader prevalence, in between 2019 and 2021, the prevalence of chronic pain in the US in adults, roughly between 20 and 21% of the entire population. That's 1 in 5 people go for a walk today and be in a public sphere and just think every 5th person struggles with chronic pain.
Yeah.
Goodness. Oh my goodness. And again, you know, to quote Janet Yellen, those aren't just numbers. Those are effing people that we're talking about, you know, who are struggling and suffering, and in most cases just left adrift to figure out how to navigate this on their own. And that's what's so devastating.
Yeah.
What do you feel are some of the most well-supported manual therapy techniques and approaches for addressing some of those common pain conditions?
One of the things that I would say about this is, and I'll just reflect in terms of how my philosophy and perspective about manual therapy treatment has changed a lot, because, you know, we sort of, Doug and I kind of grew up along the same time frame of massage education and the continuing education courses and the concepts and ideas that are out there. There was a lot of sort of fix-it technique approaches that were taught a lot through the 70s, 80s, 90s. With, you know, do these kinds of things to fix these problems. And I think for me, a lot of my perspective has changed a lot more to understanding the incredible power of the client-therapist relationship being probably more important than any of those other individual techniques are. But that doesn't mean it's not important to learn about things, because this is one of the other things, and Doug was kind of referring to this. I think the more you understand and learn about what happens in the body, the more confidence your clients are going to have in you, and the more effective you're going to be at conveying the things that are going to be most beneficial in that therapeutic relationship. So it's not so critical about, did you do, this particular type of, pin and stretch technique 4 times instead of 3 times, or, with 10 pounds of pressure instead of 12. That's not so important as it is in terms of like, how did you get that individual to respond to you and your therapeutic interventions? And are you a good fit with the approaches that you have with people?
Absolutely. Yeah, I totally agree with, and it's techniques are answers, but answers are only correct if they're in response to the right question.
Mm-hmm.
So what is the question? And what in some ways sets that up first is the human relationship. I mean, I don't want to overplay that, but for goodness sakes, we shouldn't underplay it. And, I just spoke at a national conference a while ago, and massive ballroom, everyone's an educator in an entry-level program. And when I said soft skills are really important to clinical outcomes, everybody was absolutely. And then the next question, and you know where this is going, is how much time do you spend in your entry-level program developing the soft skills, teaching that? And that everybody suddenly was looking at the floor and examining whether their shoes, because they were too embarrassed, because almost no one raised their hand.
Yeah.
So if it's so fundamental and central, why don't we spend more time? It's a skill. We call them soft skills. Any skill can be developed.
Yeah. It's certainly a lot easier to say you have to have 150 hours of anatomy and physiology in your curriculum, because that is, didactic content that you can create. It's a lot harder to say, we want to teach people clinical reasoning processes or therapeutic alliance or things like that. Those kinds of things are a lot harder to nail down and put your finger on, but that doesn't mean they're less important. It just means you got to work harder as an educator to do good things, to get those things across.
Amen. Absolutely. Amen.
Well, for massage therapists who are new to learning about pain science, what educational resources or opportunities would you send them to help expand their knowledge and skill?
I would say, first of all, there's an absolute wealth of resources available for free on the internet. There's all kinds of courses and things like that about learning about pain. There's some wonderful books and resources out there. But one of my favorite things to point people to is actually a PDF ebook created by Greg Lehman, who's a physiotherapist and biomechanist up in Toronto, Ontario, called Recovery Strategies. And he makes this workbook free, available on his website. You can go to greglehman.ca. That's Greg, GREGLEHMAN.ca, and download the Recovery Strategies workbook. It's a really good introduction to the ideas of pain science, why it's beneficial for massage therapists or any manual therapist to learn about these things, and some really good strategies for how you can do this directly in the clinic and working with people. That's a really good place to get started.
And I would also say, the prerequisite to all of this is curiosity.
Mm-hmm.
You're just not curious about that which you think you understand. And honestly, my interest in pain came when I realized I knew very little about it, and then it's like, oh gosh, if I'm dealing with all these clients who are presenting with things around which pain is a central issue, what do I know about that instead of what do I know about that condition?
Yeah.
And so I think, curiosity is fundamental, and then that leads you to discovery. And once you start down that road, there are so many different avenues that you can explore. I would say one caution to everyone, which is, under whatever you explore and whatever you discover, understand that is the current understanding. Mm-hmm. And stay tuned, because as Whit will tell you, those of us who've been in the field for a long time, you see an ever-changing thing, as it should be. So how many times do we say, oh, well, now we know, only to find out later, yeah, that wasn't really the whole story. And there's a lot that we just didn't understand. So
what's that wonderful quote from, I can't remember his name, Doug, you probably remember, the guy that was really sort of the driving force behind the evidence-based medicine practice. And I think he was the one who said that he was in teaching in medical school, and he was telling his medical students that, you know, probably 3/4 of what I'm teaching you here today is going to be irrelevant in the next 5 to 10 years. The problem is we don't know which portion of that it is going to be, you know. So
exactly. And you know, and so I think that's also why all of us need to continually just keep updating our knowledge, because the understanding that, you know, we had is shifting underneath us. And honestly, how wonderful is that? I mean, that's the reason I love like hanging around people like Whit, who just have a childlike sense of awe about all of this and wonder and discovery, because the longer you're in something, the richer and deeper it becomes. And how wonderful is that that it's an endless process of discovery. You never get there.
Yeah.
You know? There's no there.
Right.
Is there anything else that you feel is important to say that we may not have touched on yet?
I think there's probably like 50 years worth of information that we haven't really touched on yet. But, you know, the one thing I would just kind of like leave the practitioners and the listeners with is that, you know, you're going to encounter a lot of stuff out there. There's a lot of stuff, if you begin to explore this in more detail, about some moderately complex neurophysiology that you probably didn't learn in massage school. There's a lot of different things about biopsychosocial things that fall outside the realm of what we're trained to do. But the key point is to take away the things that are going to be valuable assets for you and what you can do to enhance your understanding. People are going to come to you in pain. I guarantee that is going to happen. I don't care where you work, what environment that you're in, people are going to come to you in pain, and they're going to want you to help them. And the more you can learn about some of these things and have a better understanding of what their experience might be like, the better you'll be at helping those people.
And I would say absolutely, and add to that, you know, Whit mentioned the term biopsychosocial. So when you think about it, massage therapy is uniquely positioned to have a role in each of those three realms. And the biological, you know, is there a biological effect from what we do? Absolutely. There are some really nice, some just amazing studies about that. And I think sometimes that also gets shunned to the side these days, but that is clear. And then there's the psychological. So for people, one quick example of that is attribution, right? If you think you have arthritis of your low back, there's, you know, not a lot in a way that can be done. But if that person then sees a really good therapist and 3 sessions later, their pain's 70% better, now you think, oh my gosh, maybe it's not due to something I'm powerless to make a difference about, but their attribution of what they think causes their pain has changed. And that's a psychological effect. That's really powerful. And that is part of the effect that we have. And then there's the sociological, right? Just the human to human connection. Also, that also has something to do with pain. When it's interesting, when you are invalidated, you are sort of on the outside of the group in a way, right? Like I am not accepted by my group. That's a sociological aspect. And then, so when you validate someone's experience and bring them back, they feel like now they're connected again. And that sociological aspect, we could talk for hours about. That often in the biopsychosocial is the one that gets kind of shunned to the side, and it's incredibly important. And so just to sum up again, we in our chosen profession that we love so much have tremendous potential to make a difference in the lives of the people who come to see us. And that's a great responsibility and a great opportunity to really make a difference in the world.
Mm-hmm.
So very true. I do want to just mention that we've only scratched the surface on this. There will be a full-length webinar, and we will also put links to the resources that were mentioned in this in this snippet here. So we will have those for everyone who is listening as well. Doug and Whitney, I cannot thank you enough for sharing your time with us today and your expertise. Thank you so very much.
Thanks so much for the invitation. It was great to hang out with Doug and the Massage Therapy Foundation and chat about these things.
You bet. Thanks for the opportunity, and thanks for the good work that all of you do. You are making a difference in the profession, and we all appreciate that.
Mm-hmm.
This episode is sponsored by Pain Potion, massage therapist approved fast-acting pain relief cream to soothe sore muscles and relieve stiff, inflamed joints. Wholesale pricing is available. Visit trypainpotion.com and use code ResearchPerch at checkout for 20% off your first order.
If you enjoyed this podcast, please consider donating to the Massage Therapy Foundation so that we can continue to bring you this and many other resources to increase your knowledge and improve your practice. Thank you.